make a start at this point because we have people online who are listening in today. I'd like to thank the people who come online and obviously those of you who are in the room. I'm Andrew Hunter. I'm one of the co-chairs of the Quest Centre, and I'm going to do the introduction just now and introduce Professor Jenny Donovan, who's come here today. She's going to talk to us on qualitative research and randomised trials and add-on extra or integrative opportunity. But we've got a two-part to this today, because today is the launch of the Quest Centre. The website's been up and running for some time now. Professor Donovan's talk will be online. It will be on our website after today. So there's an increasingly clear need for the use of high-quality qualitative research within trials, and the Qualitative Research in Trials Centre that we have established here has been set up to fill that clear gap, really in three main ways: to educate for trialists and for qualitative researchers in qualitative methods within trials, to undertake primary research, and to support the use of qualitative research within trials. So the main business of today, though, is the webinar, the presentation, and we're lucky enough to have Professor Jenny Donovan, who is Professor of Social Medicine at Bristol University. She has extensive experience in health services research, a degree 20 years, and publishing in this area specifically on improving the design and conduct of randomised controlled trials through methodological research. Jenny will take questions after the presentation today, and then we have
as Andrew said, I'm going to talk on this particular issue, and I'd like to start by taking this opportunity to thank all the people who work with me, who contribute to the work that I'm presenting today. Particularly, I'd like to draw attention to the Quintet team, the Qualitative Research Integrated within Trials team, who do a lot of this work. Also the MRC Conduct 2 Hub, the Hub for Trials Methodology Research, both of those based in the University of Bristol. And also NIHR, the National Institute for Health Research, the funding body that has funded many of the trials and the studies that I'm going to talk about here today. So my aim today is to talk about what qualitative research can offer trials, both in terms of the sorts of studies that are added on run alongside trials, and also those that are built into and integrated within trials. I'll give you some examples from some old and some new trials, and then perhaps at the end we can have some discussion around the key issues in adding qualitative research to trials or integrating them together. Oops. And just to start by saying, what sort of relationship between trials and qualitative research do we want? Trials are held up to be the highest level of scientific evidence, and what tended to happen in the past in particular, but still to some degree, is that as qualitative researchers we're kind of allowed to bring our qualitative approaches in studies alongside these trials. And I think it's important we get inside the trials, working with the trialists, with the clinicians, and with the trials units, and really showing the quality and insight that qualitative research can bring to trials, but also to appreciate the opportunities that we have as qualitative researchers working with trials. They're extremely interesting studies and provide a lot of material for us, just as well as we can provide a lot of insight for them. So we need to get in there, being more equal partners, I think, with trials and trialists, and that's been my aim over the years. So just to digress a little, what sort of quality research methods are we talking about? And you're all familiar with the traditional quality methods, I'm sure, the focus groups and interviews, observational approaches, not always with binoculars, but here in this graphic. Also, I'm thinking about the old-fashioned qualitative methods, if you like, the ethnographic methods, the really detailed, high-quality methods that actually you can bring to bear in trials in terms of looking at the trial as a cultural system, because they are very interesting cultural systems. But the problem with a lot of quality research and high-quality quality research is it takes quite a long time to do. And trials are very fast-moving once they get started. And so we have a real issue, I think, as quality researchers to get our methods adapted in such a way that we can meet the needs of trials in terms of trial timelines, but also that we hold on to the key bits of our quality research methods that keep the quality. Because what we don't want to do is do quick stuff that's not high quality. We've got to do high quality work to tight timescales. And that's tricky. We need to build new methods, develop new methods, and we're certainly doing that in our group, and I know that will be an interest that will be pursued here. So in terms of what quality research can offer trials, there's a lot of work, very good work that's been done understanding participant perspectives and particularly looking at experiences of symptoms, experience of recruitment and outcome and so on, looking at clarity of study information. A lot of these studies run alongside these trials. They're kind of add-on studies to some degree. And and those are really good, and we need to continue to do those studies, but there are other opportunities. And the thing I want to talk about is the kind of integrative and dynamic research opportunity that we have running alongside trials and really working within trials in a more integrated way. And I'm going to talk particularly about recruitment because that's the area that I've done a lot of work in with the team that I have. And recruitment is also an interesting issue because it tends to be identified by trialists as the most important or most difficult intractable issue. And we know that most trials have recruitment difficulties at some stage or another. Some do okay, but most of them have difficulties. And so within the Quintet team, we've developed an intervention. We call it the QRI, named after the Quintet team. And it began a long time ago, more than 20 years ago, in the NIHR Protect trial, which is a prostate cancer trial. And it was a trial that everyone thought couldn't be done because the arms were so different. It was surgery, radiotherapy, and no new intervention. And we managed to do that. And I'll come back to that example later on. Having done that, we then honed the methods and have been honing the methods over the last 20 years or so in this team, putting this in lots of different trials. The trials that we worked on have mostly been trials that are really challenging, that are difficult, ones that were difficult to recruit to because of different arms or different clinical groups, for example, ones where they haven't done trials before, or different areas, difficult areas like surgery, where it's known to be difficult to do trials. And the QRI itself has a very simple conception. The first thing to do is try and understand recruitment. And it's very interesting, a lot of the research that's gone on before has tried lots and lots to develop lots of different interventions, but has not really understood the processes. And that, of course, is exactly what qualitative research does, understand what's going on. Once you've understood it, then you can begin to think about how you might optimize it. And the key aspect of the QRI is to ensure that there's really fully informed consent, because it's a really important issue. Lots of patients want to take part in research, but it's absolutely essential that they really understand what the trial is about and give full participatory consent. And that's at the heart of what we do. What we find is if you do that, you actually increase recruitment in most cases. So Quintet recruitment intervention itself is in 3 stages, although they're iterative, as I think the highest quality research is iterative. There's a first phase where, as I said, we understand what's going on. We do that by looking at screening log data. That's not particularly qualitative, but we look at the patients that have come in and where they've fallen out of the recruitment process. We do in-depth interviews with the investigators, with the people who designed the trial to work out exactly what they think they're doing, what their perspective is of what they're doing. The key aspect is audio recordings of recruitment consultations. This is where the recruiters actually try and recruit the patients. They talk to the patients about the trial itself, and the patients get the opportunity to ask questions. And when you recruit that, you really find out what's going on. You can see what people really say. We do a number of other things, but it's the audio recordings of the appointments that make a big difference. Once we've done that, and we try and do that really quickly, we try and do it within 3 months or 4 months if we can, then we present the findings back to the chief investigator of the trial management group and plot between us what we're going to do about it. What does the chief investigator want to do in relation to those findings to improve recruitment to the trial? And we can offer things like training sessions, we can talk to the clinicians, we can give them individual feedback or group feedback, we can facilitate discussions amongst the clinicians, we can provide them with tips, documents and so on, and amend the information. But it's their responsibility, the trial's responsibility. And in the final phase, we essentially monitor the effect of what we've done and see what else changes, because interestingly enough, you never quite get a handle on recruitment. It can change, so you have to keep looking at it and evaluating the impact of the interventions that you put in place. So we wrote up the first decade or so of that material, and all our understandings of these various trials. For the first 6, we really looked at those in detail and came to the conclusion that there were clear obstacles and hidden challenges to those trials. There were a number of clear obstacles. If you ask trialists what's going wrong with a trial or trial units, they'll tell you a whole list of organisational problems. And of course they need to be sorted. But I'm not going to talk about those anymore, because you can hear those from anybody who's involved in trials. What we also discovered was that there were a whole load of hidden challenges, and those hidden challenges were intellectual issues, but also quite interestingly very emotional issues. And I think we were all quite surprised by that. The other thing that's surprising, although not given the name hidden, is that these issues were not really shared with colleagues. They weren't shared with the trial organisers. And also, when we discussed them, that they weren't perceived to affect recruitment, which was very interesting. And I'm not going to read these out, but these are the intellectual and emotional issues that we think of as our hidden challenges. Now we keep adding them and refining them, because each time we do a new trial there's slightly different issues, but these come up continuously. And I'm just going to pull out a few of them just to give you some examples. And in true qualitative style, I'm now going to talk about some quotes from participants. So these are quotes usually from participants and recruiters, sometimes surgeons, sometimes not. So here's one about commitment to the trial. So the surgeon says, to go into the study, it would involve treatment A or treatment B. The patient says, that's interesting. The surgeon goes on to say, so the most important thing is if you decide you'd rather have treatment A or treatment B, and the patient interrupts and says, I'm pretty ambivalent really. So this is a patient who looks ready for randomisation or discussion about randomisation. But what actually happens next, you'll be surprised to know, the surgeon says, well, okay, but don't make that decision today. If you can't make your mind up, consider the study. But if you don't want to do the study because you're not thinking, you think it's too much bother, you don't have to give us a reason, it will not alter the way you think about you. It's simple, you can walk away at any time. So of course what happens? Does the patient get recruited? No. They're delighted, they don't have to think about it anymore. And of course this surgeon was extremely committed to the trial, in theory, but not quite in practice. That's why it's a hidden challenge. Another hidden challenge is that recruiters have lots of different roles. If they're doctors, they're recruiters, they're scientists, they're clinicians of some sort. If they're nurses, they're recruiters, researchers, they can be clinical nurses, sometimes they can think they're patient advocates. And all those things, they can work perfectly well, so they can be very comfortable. So this person said, I see my role as a researcher and as a clinician, engaging patients in the community over a long-term relationship to improve clinical uncertainty. So some people are very comfortable in their roles. But of course, some are less comfortable. And here's somebody who said, but there's always a conflict between the patient sitting in front of you and their wishes, and wanting to take part in the trial, and wanting to support it to increase recruitment. And you begin to see some of this discomfort, this emotional baggage that's going on. Another hidden challenge is Equipoise. There's been a huge amount written about the theory of Equipoise, but almost nothing about how Equipoise plays out in a consultation or how recruiters deal with it, and they deal with it they find it difficult. I think that's the obvious thing to say. Some don't. Some find it a comfortable position. So this one says, "I don't know. I believe that's why I've got Equipoise. I don't know. You don't know. Nobody knows. That's why it has to be randomised." So that's clearly a very committed recruiter in Equipoise. But does Equipoise mix with clinical practice? Often it doesn't. It creates these discomforts. So here are some quotes from other clinicians who say there's a proportion of patients who will say to me, "Well, what do you think, doctor?" Very common thing. And in that situation, I think my gut feeling is important. I always tell them. So they'll tell them that one treatment is better than another. So they won't go into the trial. Another one here says they'd be compromising their treatment by taking a risk with treatment. See, they understand that after I've told them. Again, recruitment won't happen. Do they think it impacts on recruitment? No. They think they can stand back from those views and that recruitment's fine, but actually the Equipoise is completely lost. Another hidden challenge, patient preferences. Again, this is seen to be quite a straightforward thing. Patients have treatment preferences. They should be allowed to have treatment preferences, of course. Some people have treatment preferences that are strong and well informed. But actually, do they all have, or do large numbers of patients have strong treatment preferences? We find they don't. But this is a very common excerpt from a consultation. The recruiter says, "Have you had a chance to look through the literature given in the clinic and think about the different treatment options in the trial?" And the patient said, "Yeah, I did. I mean, I think I'd like to go for option A. That's what I think." So if we're training this recruiter, we'd say that gives you an opportunity to discuss the trial, to discuss whether this person would participate. What actually happens next, the recruiter says, "Okay, that's fine. Let me look at dates when you can have that treatment." So again, these issues are hidden. Similarly, terminology. I'm sure a lot of you know trial terminology is not the same as lay terminology. Words like trial and random have different meanings in lay audiences. And so we need to be careful how we use those terms because they come with a lot of baggage, a lot of load, if you like. So that's the QRI in summary. What we found out from doing this work is that the recruitment process is complex and fragile. There are these obstacles and challenges. Recruiters often want to do the right thing, but somehow all these intellectual and emotional issues that are going on mean that they don't quite do the right thing. But you can help them do the right thing. The really useful and important aspect of this is that you can challenge these things. You can open up the discussion, and actually, in the second part of the QRI, we find that once you get these issues out into the open, you do some training and support, often you can increase recruitment and improve the way clinicians feel about trials. And this is an example of recruitment to a trial. You can see the expected recruitment, the dashed line, and the actual recruitment, the green line. And as you can see, recruitment was pretty non-existent while we were trying to work out what was going on with the recruitment. We then worked it out, gave some feedback, and recruitment improved. Of course, you can't read, it's observational data, so you can't prove that it was the QRI that did that rather than something else. There were other things being done, but we think it was the QRI. And then at the top, you'll notice just at the top, you never quite fix it because you can see the recruitment going off again. And I'll explain that in this trial. It's a 5-band trial. I should have credited it, but I'll come back to that in a minute. So how is studying recruitment an integrative opportunity? Well, the QRI, as I've described it, provides understandings about all these things: equipoise, eligibility, compliance with protocols, commitment of investigators. These are key trial issues. And what then needs to happen is the RCT the chief investigator of the RCT needs to respond, probably in terms of the design and conduct of the trial. So the quality of research can inform that aspect. And so I'm going to give you an example of that if I can make it work. So I'll talk a little bit more about the PROTECT trial. So this is the prostate cancer trial. Again, I apologize for the busyness of the slide. I'm not going to go through all these aspects. The paper reference is below. This was the difficult trial in prostate cancer treatment. So all sorts of issues in the feasibility study about whether it should have 2 arms or 3 arms, who should do the recruitment, what the non-radical arm should be called. And all those aspects were informed by the qualitative research. We ended up deriving a new treatment called active monitoring, specifying what that was, making sure that represented what where the Equipoise position was. And the trial was a 3-arm trial, and it's finished recruiting, and we'll publish its findings shortly. We began to realize that a lot of these issues were generic to other trials. And so when you're doing a QRI in this sort of way, you're having an influence on these other aspects. So another example is the BIBAN trial, the one I mentioned before. Chief investigator of this is Jane Blazeby. So this was also an issue about, is this trial feasible? It's comparing gastric bypass with gastric band. As I showed you, we started doing the recruitment process successfully. But in the meantime, another treatment, gastric sleeve, was developing across the surgical community. That became stabilized. And then the clinicians wanted to talk about it in the recruitment appointments. And all of a sudden, recruitment, as you saw, flattened off and wasn't working any longer. So the chief investigator and the team worked together to bring in this new arm so that the trial design was changed. It became a 3-arm trial, and we're continuing with recruitment on that trial. But that's another example of where the qualitative research has really changed the design of the trial. It's gone from BIBAN to BIBAN sleeve. So there are other opportunities, I think, an enormous number of opportunities for qualitative research and trials to work together in these integrated ways. And feasibility studies are another key aspect. And I couldn't imagine doing a feasibility study that isn't hugely involving qualitative research. In fact, the PROTECT study, when I started it, I rather provocatively said that the trial was nested within a qualitative study, which rather upset some trialists at the time. But I think in some ways that's true, but actually it's more of a collaborative affair than anything else. And in feasibility studies, of course, you're interested in all sorts of things. You're interested in recruitment, organisation, the acceptability of the interventions from the patient's perspective, what sort of outcome measures you should use, whether the staff are going to work together well. And those sorts of things all benefit from qualitative research. Just to give an example of this, this is another study called Bluebelle, also the same chief investigator, Jane Blazeby, in Bristol. So this question posed by the NHS was, what sort of dressing should you have after simple surgery, elective surgery? So should you have simple dressings, cheap ones? Should you have complex dressings, rather more expensive ones? And maybe actually whether you should have dressings at all for surgery. And that's quite an interesting question. The reaction of most people was to say, you'll never get that off the ground. Patients are never going to accept not having dressings. Clinicians will have very clear views about the sorts of dressings that they want to use. So a feasibility study was done. It had an integrated qualitative study, and that was led by Leila Ruchinas in the Quintet team. But there was a teamwork. So the team got together, 4 researchers, and they did over 100 interviews. So this is rapid qualitative research. It was analysed using the usual methods, and all sorts of issues arose from this. So there were questions about what is a dressing? How do you define a dressing? Does it have adhesive around it? Is it those steri strips? And then the clinicians were talking about this new innovation that had come in, blue. And that hadn't even been on the radar of anybody at this point. So all those issues emerged. Goodness knows what would have happened if we'd actually started a trial, because these things had to come out, they had to be discussed. So then we discussed with clinicians, so what about this complex simple dressings issue? Most of them haven't really come across complex dressings for simple, for surgical wounds after elective surgery. So all of a sudden the trial design, the original design, is not going to work, is it? This clinician said, you know, I've not heard of complex dressings, I either use a simple one or this new technique of glue. So the trials have to be completely redesigned on the basis of this. It's now going to be a trial of simple dressings, glue as a dressing, and compared with no dressing. And again, the issues about whether patients would be prepared to not have a dressing on wounds has been very interesting, because actually there's an old wives' tale that if you put a dressing on a wound, you actually seal in the bacteria. If you take the dressing off, you actually let the air through it, and it dries off quicker. So, you know, which of those is right? Patients actually now agreeing to be recruited. I think this has got over 100 participants in it now. So the integration that we have can continue as well as the trial proceeds. I think feasibility studies are a key area for quality research to get involved in. But you can also, there are also incredible opportunities in full-scale trials during the recruitment and follow-up processes of trials when they're doing their main business. Because recruitment never changes. There are always problems with recruitment, on and off, and they change. There are issues around what's the experience of participation in a main trial. There are issues around the interventions. The fidelity of interventions? Is the intervention delivered as it's supposed to be? Is there compliance with the interventions? Do the participants actually have the interventions? There have been many trials that have come out with null results, where people have been wondering at the end of it whether the interventions were actually applied as they should have been, because the trials can provide evidence which is difficult to interpret. If you can understand the interventions and the experience of them, if you can understand all these issues to do with the interventions, perhaps we'll be able to contribute to the results of the trial. So there's all sorts of these opportunities, and certainly with your centre you have the chance to look at these things. So I hope I've shown you that there's lots of opportunity with integrating RCTs and qualitative research. There are opportunities for all of us, as qualitative researchers, as trialists, as those involved in this whole enterprise. And we should all be in it together, I think. It is the sort of work that requires everybody to think about it. These trials are, of course, really important for making decisions about the sorts of treatments we all have, we will all experience in our lifetimes, our families will experience. So we must make sure they're the best they can be, that we have the best trials that we can. And in order to do that, we need to have methods, including qualitative research, to help ensure that we make the trials the best they can be. And as I said, you've got your centre here called Quest. You'll be able to do all that sort of research, and I wish you very well with that. Best.
Thank you, Jenny, for that. Now, we are hopefully going to have some. Hopefully, we will have some online questions. But first of all, I'd like any questions from the room. Is anyone that's got any? And I'll bring the microphone up to you. Microphone for online.
Thank you very much, Jenny. I wonder, have you much experience of doing either one-to-one interviews with trial participants versus corporate participants? And maybe you could tell us a little bit if you do have that experience, I suppose, in terms of where you felt even if those methods have worked well.
Yes, that's an interesting question. Of course, you can use both methods, and it depends what you're doing, I think. I mean, the key thing with focus groups is that you're really aiming to get some sort of consensus. So if you're looking at developing an outcome measure for a trial, then getting a focus group of patients together can be quite helpful, because they can talk to each other and come to some conclusions on a group basis about what's the most appropriate outcome measure. If you're talking about experience of an intervention or experience of participation or some of these aspects to do with recruitment, then one might well need to do in-depth interviews because those will give you richer data. I think the focus groups. Focus groups as well are quite difficult to analyse sometimes because people tend not to quite finish the point they're making, whereas in an interview, the person's got to finish off what they're saying because you're not going to say anything until they do. Whereas in focus groups, people interrupt themselves, don't they? Interrupt each other rather than not themselves. They interrupt each other, and then sometimes you don't quite get the data you need.
Any other questions?
Yes, that is a very interesting question, and it is something that I've been asked a lot in the past, and I would go back to the issue about we want trials to be the best they can be, and at the moment, all these hidden challenges that I've mentioned are going on in trials all over the place where we haven't found them. And so the trials are being designed and conducted in ways that are not optimal, I think. And we know that because so many trials produce findings that people find difficult to interpret. And clinicians do struggle a lot with using trial evidence in their own practice. And that's often because trials tend to recruit participants of particular sorts. They don't often always include all the patients that you'd expect to see in a clinic setting, for example. So, and that makes it difficult to But if we make trials more generalizable, if we ensure that they adhere to the highest methods of the conduct of trials research, they follow the protocols in a detailed way, I think we do need to find out whether they're being conducted appropriately and what's going on so that we can use that information to interpret the findings of them. Also, to make sure that they're conducted as well as they can be. So, in many trials, if you look at recruitment figures, you see that 2 or 3 or 10% of participants who are eligible for the trial will be recruited to them. They don't represent the patient body, even in the clinics. And so, the sort of recruitment methods I've talked about here, we recruit 50–60% of participants, and that makes the trials more generalised. These issues about interfering with trials, yes, it's true, but that we can have an influence, and that you may worry about that from a statistical point of view. But if you knew that there was something that wasn't making your trial optimal that was going on, wouldn't you want to know about it and deal with it? Because it's going on. The question is whether you want to know about it and then whether you want to do something about it.
Thank you. So just in terms of you talking about some of the issues like Equipoise, for example, it has to be considered in detail, but it strikes me that doing this work might also generate some information as to how those questions, how you present Equipoise, might be asked, and transform the design of some kind of methodology work. It's very difficult to pin down exactly what the people might be thinking. The absence of the proposal.
Yes, Equipoise is a very interesting issue, I think, because in itself it's an odd concept that the clinician has to sit there and think, is this patient in front of me is not going to be disadvantaged by having any of the arms in this trial, and as we've discovered, that creates a whole raft of discomfort for lots of clinicians because they'll be looking at an individual patient, so that there may be community at Equipoise. So you have the community of clinicians who are not sure which treatment is best. But a lot of clinicians will be extremely clear what they think which treatment is best. And as in our IBAN say, there are parts of the country where if you live in particular cities, you will get a bypass, and if you live in other parts of other cities, you will get a band or a sleeve. And it's entirely because of where you live, because the clinicians in those particular areas do those procedures. So one then has a community of experts, but then as a patient walks into the clinic, you then have all sorts of personal characteristics and issues around whether that person will be suitable for the trial, whether you have equipoise in that particular situation. And we've found that there's a kind of in most trials, which are really important questions that the clinicians are committed to, there'll be a group of patients that they're quite comfortable with. And then there'll be, on the edges of that, there'll be these patients where they're less comfortable. And raising the issue about that, you could discuss it using qualitative methods. There's no other way of doing that, I think. You discuss those issues, and actually clinicians can share with each other where their equipoise lies, and you can gain a different place for the equipoise. So, for example, in the prostate cancer trial when we started, there was almost nobody in favour of no active intervention. Now it's an established treatment, and that took quite a bit of time, but it was interesting. And certainly equipoise is an amazing fertile area for all sorts of research, I think. We're only scratching the surface, I think.
Another online question.
Second question from Frank. How many of those people who are clinicians undertake discussion important in circumstances whereby the clinician is not being anonymized?
Thank you. Again, that's an important question. I mean, we have to anonymise them. So it's really important when we do any presentations of material, as I've done today, the clinicians' names clearly don't appear. We anonymise them as much as possible and take away any identifiers. We also do that when we're discussing within particular trials the issues that are around. So quite often we'll get investigators together and put up the quotes. We always anonymise them. But what's interesting in your comment is that in many cases the clinician will say, "That's me, that is," as we put a quote up, and then they may argue about whose quote it is. And because the idea of this is not to identify people and make them feel bad, the idea about this is to do these investigations to help improve communication skills, essentially. What we do in those feedback discussions are we show what's been said, we show what the patient's reactions are, and then we invite the clinician to discuss how they might do it differently. Because quite often, anyone who does those sorts of consultations will know the consultation goes quite well, the interaction seems to go well, and then all of a sudden it will not go well. And you don't usually know why. And the advantage we have if we've recorded it is we can rewind and work out why it's gone wrong. And quite often it's because of a term that's being used. So, for example, in the prostate cancer trial, a number of clinicians were using the term early prostate cancer, which is a perfectly reasonable thing to do. But for the patients, that suggested that they certainly didn't need radiotherapy or surgery because the disease was early. Now, there was absolutely no way that you would know that as a clinician in an interview setting. We then suggested they stopped using the word early and the recruitment continued to go. But you're absolutely right, anonymity must be preserved.
Any more questions?
So I'd like you to describe that the trial was nested within the qualitative study, so I'm kind of funny way to describe it. So I'm wondering in general how open you can try to the value of this type of qualitative research, not really as an add-on, but like an integrative part of the research.
Wait, I should wait for a minute. So yes, again, very interesting point. I think in the early days, it was quite interesting because I did suggest this idea to the MRC trials unit, which was the premier trials unit, and they were not keen on it at all. And but over time, I think it's got a lot easier, and I think increasingly clinicians are interested in doing. Clinicians always want to do the right thing for their patients, and increasingly trials. They want to get involved in trials, and it seems to be a good thing. But what you need to do to start with, I think, is to have open-minded clinicians who are willing to work with quality researchers. And that, you know, I happened to form a very good relationship with a surgeon, a pair of surgeons, in fact, Freddie Hamby and David Neal, and we talked long and hard about how we would do this trial, this prostate cancer trial. And we knew it would be extremely difficult, and so we just basically pooled all our expertise. And because that worked, that then gave me the opportunity to talk about that trial to other people, and then gradually other people got involved. And I have to say, people like Jane Blazeby, who leads the surgical research unit in Bristol and the Conduct Hub, has done an amazing job with introducing surgeons to this idea. So surgical trials were very few in number and not usually of great quality in the past. But the whole surgical community has changed, and they now want to do trials. And because they've seen some of these trials that we've been doing, they want to join. So actually, in some ways, the world has turned around. And once you show chief investigators this kind of stuff, they want to work with you. And I'm sure you'll find that here when you start doing work, more of the work with quests. You'll have lots of PIs who want to do these questions that everybody kind of thought we couldn't do, that are really important clinical issues. Actually, once you've got quality work on board, you can start to think about doing them. It's not easy, it takes a long, long time, but you know, they're as up for it as anything now. And in fact, you know, we now even get phone calls and emails saying, why haven't I had my feedback? Which is rather different to our questions about why haven't you recorded your appointments. You know, they're now recording the appointments and they want the feedback. So I think things are changing. Not everywhere. We've still got work to do to attract other people, but yeah, it's changing.
Do we have any more questions on that? Can I ask one? Jenny, have you seen any evidence of a change of what we're coming to is, are funding bodies now looking for these quality components in trials, and have you seen anything, you know, to sell it to the PI of the future? How can we say there's been a change there?
Yes, that has also changed. I mean, funding bodies like our National Institute for Health Research have, for many years actually, probably for 10 years or so, have invited quality researchers to be involved. You know, they want trials that have statisticians doing the medical statistics. They want the health economists doing the economic evaluations, and they want quality researchers helping to organise the recruitment and understanding how the trials take place. So certainly, that funding body has made a huge leap in that direction. I think other funding bodies too. We have a number of our charities that are now starting to think about that. I think your own Irish Research Board also invites some quality research services in its trials. So you know, it's important to take those advantages. And the MRC also has a methodology program which we're hoping to put some quality research into, so that there are, yes, certainly increasing opportunities. And of course, as funding gets more and more constrained, the sorts of studies that are least likely to be constrained are probably going to be trials. So getting other studies funded is going to be difficult, but we still have an opportunity with trials to really work together on them. Yes, that's an interesting question. So I think, like most things, it kind of varies. Some people find the idea of recording themselves absolutely awful and find it difficult to do the recordings. But when they do the recordings and we do the feedback, we try to do a mixture of things. We do some individual feedback and some group feedback. I think most people like the individual feedback because with that we can actually sit down for a period of time. We can look at some of the consultations, and if the clinicians told us in advance of one that really they don't understand why it went not so well. Sometimes they're very conscious that the appointment was going quite well and then it didn't go very well. And we can look at the transcription of that with them and see what might be different. And people often like that. They also like the idea of things that might be quite simple to change. So, and often they'll want to have the feedback in stages. So they might change something relatively minor, first of all, to see whether we're right or not. Because obviously, what tends to happen is you have a fairly standard spiel, a fairly standard set of words that you use in appointments, which you've honed over the years, which works reasonably well. Now, trials are very different to clinical practice, so you have to change the spiel anyway. So, and they know that. And the other thing is, if we can show them that we can help them talk about trials in a shorter time than actually they would have done before, that can also be very helpful. But certainly, the individual showing that. Starting off perhaps with not using the word trial or explaining randomisation in a clearer fashion, and we might give them a form of word. If they try that and it works, then we can try some of these rather harder issues about perhaps it's best if you don't recommend the treatment you normally do in the context of a trial where there's another treatment which is completely different. And we can show them that unwittingly they've betrayed their views and they can't actually quite put their beliefs aside as they sometimes think they can. So, but we also do group feedback, and that can be very interesting because you put up the quotations or you put up the issues, and then you let the clinicians talk to each other about what the solutions to that can be. And that can be incredibly powerful because they like to talk to each other and they like to learn from each other. And so that's another format. When you can get people together, that's another great way to do it.
Any last question there? Thank you very much, Jenny. So I'll just wind up now, and I find it really reassuring to see that this kind of work is developing, can be developed, and that there is an appetite and a changing appetite for trialists to take this on, and for us to, that'll stick with me, for us to wrap their trials around our quality or within our qualitative research. And I hope it's got you thinking about yourselves, about the trials, your next bids, whether you're a qualitative researcher or whether you're in contact with a PI or looking towards a bid now, and how you can bring qualitative research and really enhance the quality of the trial as a whole. And the qualitative research in Trial Centre is here for just that. It's to set up a network of people, whether you be someone with the qualitative skills to come in and work with us, or whether it's a case of who do you know that's a PI, who do you know that's putting a study together, so that you can that we can build this network together here. So that just leaves me now then to again thank the online audience for their participation and for their questions. Thank all of you who've come here today. Anyone who's in the room, sorry, online people, there is wine nibbles up on the 3rd floor for you just now. And I'd just like to again, so straight afterwards, and we thank Jenny again for her work today. Thank you.